Okay.
So over to you, Martin Knapp, who, as I was saying, probably needs no introduction, but from this part he's going to tell you who he is anyway.
He sometimes needs an introduction to his family, but there we go. So just two quick comments to begin with. I'll go through very quickly what we're going to do. So first of all, to say we've heard some elements about MODEM already, and I'm just going to tell you about the core part of it, and you've got the leaflet, and that tells you quite a bit about that core. So that's one thing to say. Secondly, we've got a logo. It's not a logo, so we're not allowed to have a logo. But ESRC and NIHR are going to sort out a logo that we will have at some point. So that's the shortest lived logo ever, probably. Thirdly, two things for context. The public context, the Care Bill has become the Care Act. So that's now cemented in place. Lots of things that we know are going to shape, probably for many years, the structure of long-term care. There are other things around. There's lots and lots of policy documentation now around dementia, lots of things coming out of governments elsewhere, lots of things coming out of organisations like Alzheimer's Society, so lots more attention being placed on dementia than we've had for a long time. And the other bit of context is personal. Two things. One, by 2040, when this project finishes, or the projections finish, any funders in the room, it's a Freudian. But by 2040, I've worked out the probability I'll have dementia will be about 50%, if I'm spared. Okay, so I'm kind of keen that by the time we get to that sort of period, things are pretty good. But also a very personal thing. On the day that our project started, my mum phoned me up and told me my dad had been diagnosed with dementia. So I want care for people with dementia to be as good as possible, as soon as possible. Okay, so we all have those connections, and over time, more and more as well have those sorts of connections. Final bit of introduction, and I'll just show you some quick slides. I thought, given the timing, I've done a Twitter feed for somebody. So this is MODEM in 140 characters. Okay? MODEM projects dementia needs, costs, outcomes to 2040. Then shows what costs and outcomes will be of better prevention, care, support, hope. Okay, so that's what we're doing. I can stop now if you want to, or I can just show you very few slides just to give you a bit more detail. So you've seen some members of the team already. There's quite a few people involved. These are the people who were the PIs on the bid, but also a number of colleagues in the room here today from LSE and elsewhere who are already working on the project. So it's quite a big activity. Not many people working full time on it, but lots of people contributing in important ways. So it's a collaborative study bringing together many of those skills you've heard already. What do we know? I should have put the word we in there, but in the future we will spend much more on the care of people with dementia. These are the sorts of things we've seen. Somebody was telling me earlier, what is it, by 2020 is it? The cost of dementia worldwide will be $1 trillion or something. So this is the ADI estimate, I think. So we know the costs are going to be enormous, and costs are only just a very simple way of summarising a whole range of experiences and difficulties and challenges that people experience. So the challenge is clearly there. Now, what are our research questions in MODEM? There are 4, basically. How many people with dementia will there be between now and 2040? What will be the costs and outcomes of their treatment, care and support under present arrangements? So similar to what Adelina was saying, that she and colleagues have done in the past. Thirdly, how do those costs and outcomes vary with the characteristics and circumstances of people with dementia and their carers? And how could costs and outcomes change in level and distribution if we use best interventions? Now, interventions, we mean these sorts of things. Prevention, a whole range of things. Treatments, care and support arrangements, such as, there are them up there actually, but care navigators, dementia advisors, case management, as well as the sorts of things that are there. So the focus, when we say intervention, is just a shorthand term for a whole range of things. And then we're interested in a whole range of consequences of those things. So what will be the resource impacts for the NHS, for the social care sector, broadly defined, for others, particularly for people with dementia themselves, out-of-pocket expenses, and of course for their families and their local and other communities. What will be the quality of life, clinical and lifestyle effects? Some things we've heard about already, and we're also very interested in care outcomes. So we will then be looking to see what do we know about interventions, defined in that quite broad way, that seem to work. You know, I'm not convinced yet the evidence is quite there on exercise. It was quite encouraging. I'm sure there's something there. Certainly exercise as a preventive factor for coronary heart disease is pretty good, and its impact on vascular dementia. So, if the evidence is good enough in these areas for us to use, then we put it into our modelling. There's lots of evidence. I'll show you 2 slides in a moment of treatments where we've got good evidence now. We'll put them into our modelling, and then we will see how we can put together a better care and support and treatment package and prevention package for the future. So 2 examples. This is CST, cognitive stimulation therapy. One of those things that's been around for quite a long time now, works, doesn't get delivered very often, unfortunately, for some reason. Works not as often as it ought to, perhaps I should say that. The evidence is there. The evidence is there that it works in the short term. We've been involved in the study, doing some economics part of the wider study, which shows it seems to work if you give a maintenance dose, if you like. You continue with cognitive stimulation therapy beyond the initial 8 weeks, which is what's previously been studied. So here's something that looks effective and cost effective for people in the mild stage of their dementia, and it seems to work, seems to be good in terms of carer outcomes as well. Here's another intervention. This is the START intervention, START trial led by Jill Livingston. Again, we were involved with the economics bit of it. This is a support arrangement for carers, giving them a coping strategy, delivered by psychology graduates with a little bit of training, not clinical psychologists or other expensive professionals that are hard to find. It works. It works in improving carer health and carer quality of life. It works up to 8 months. We've just found that it works up to 24 months. And it seems to reduce the rate of admission of people with dementia into care homes. So again, I'm just choosing 2 where we just got some recent evidence. These are the sorts of things we will want to use evidence of this kind and put it into our modelling. So we will have these wonderful words. You couldn't get this into Twitter without too much. But what Carol described, her dynamic microsimulation models and so on. We're using data on individual people and then trying to understand the course of their needs, the course of their disease, their illness, their support arrangements and so on. We will also be interested in the care pathways and how different interventions, the sorts of things I've been talking about, would maybe change those care pathways and change the service use patterns, the costs and the outcomes. And then what we'll do is then use that to go into a macro simulation, so looking at an aggregate level modelling basically, to then say what the consequences would be of rolling this out, making these interventions available to everybody in the population with the relevant needs. What will be the consequences in terms of hopefully reduced costs, hopefully, importantly, better outcomes, not just for the person with dementia, but for carers. So, 2 slides to finish. What goes into the models? Lots of stuff. Okay, lots of stuff goes into the models, including stuff you give us today. So we've got a board outside. What does dementia care look like in 2040? Tell us what you think. We'll get back to that in discussion a bit later this afternoon. But we will use data, obviously from the scientific literature, from these big data sets, the sorts of things that Carol and Emily have mentioned already. But we also need the experiences of people who are working at the coalface, should we say, people who are in day-to-day contact with dementia as a person with the condition, as a carer, as a frontline worker. So we will use that information to try and help us to understand how we interpret these interventions and go forward. I've got about 10 slides in here which are ever so technical, which I'm not going to show you. So I'm going to show you 2 slides to finish. Finally, a legacy tool. What we want to do with this, our modelling will be complicated. We will, at the end of the project, bring it down to a much less complicated summary. We want to make sure that, having done all this painful work, it's helpful to other people, not just in the results that are around, but people can have this tool as a modelling device to do their own thing. Okay, so whether they're commissioners or strategic decision makers or individual people interested in their own circumstances. So we will get something together which will be available for people to do that. And so how can you help? Well, you can tell us if you'd like to be involved in one of our groups, so please feel free to volunteer. We will see how we can bring you in. We definitely wouldn't want to turn you away. Tell us about new developments as the project goes on. We'll have a project website very soon. Be our critical friends. We definitely want critical friends as we go forward with this. So on here, we now have an email address, as of yesterday, I think, for the project. So you can email us. You can obviously email Adeline now or myself or anybody else in the project team. But to do that, it'll go through. It'll be more efficient if you email me. And we'll have a project web page very soon. We can't put it up there yet because we're not allowed to put a logo up. So we don't want the funders to be too embarrassed by that, but they should have had that sorted out long ago. Right. Thank you very much.
Great, thank you, Martin. Do so there in case. I think we'll ask Martin to take a couple of questions before tea, and then maybe, if they're very complicated, he can feed back to the panel. We're the best informed people about this project in the universe now. Has anybody got any questions? What should they have done? What needs to be done more? And here's the guy with the mic. Gentleman at the back. Daniel.
Ken Crawford, can you hear me? Ken Crawford, and I belong to something called Devon Senior Voice. We're an old police and persons organisation, and we've been working to help people with dementia since 2008. In that time, we've helped establish over 30 memory cafes. So we're helping in that way. We want to do as much as we possibly can. But I wonder whether one of the questions that you ought to be putting to people is the cost effectiveness of intervention. We, on these 30 memory cafes, the average cost of running them for 1 day a week is £500 a year. If you look at one of the most popular interventions, which is singing for the brain, Alzheimer's will tell you it costs £11,000 per year to set one up, and £7,000 to actually run it. So one of the things I would ask you to look at is the cost effectiveness of using volunteers. All our memory cafes, apart from the 4 Alzheimer's ones, are actually run by volunteers. So start to think about using volunteers.
Yeah, I mean, absolutely. I mean, that's what I say in the previous slide. We're very keen to get this kind of information back. I knew some of that, but the costs were very interesting to hear. We've done other work. We're doing other work at the moment looking at the role of communities, for community capacity building, the roles of communities in supporting people with social care needs or preventing those needs emerging. And yes, they can be enormously attractive from the economic point of view, as well as very effective, because they do utilise the unpaid labour in communities. And those people that are delivering as volunteers often get lots of benefits themselves. So we will, through your eyes, definitely be following that up. So I'll come and talk to you in the break, or I'll find you via email space.
Great. Time for another question. Legit.
Just very quickly, one of the things that, for me, dementia is never cured. It's about the care part of it. And having had both paid care workers coming into the home and now my father being in a home, what concerns me, which has been in the news, is the training. That because some of the care workers we had in the home, they were not specifically dementia trained. And also the fact that you don't necessarily always have the same person coming in. Now for me, my father was fortunate because I used to speak up for him and I used to ring up the private provider and say, this is not good enough, you need to have. So how can we build that in? Because to me, sometimes a lot of money is wasted on not providing the right trained people right from the very beginning, which is also part of how many hours do you need to...
No, I think that's absolutely right. I mean, we've done a piece of work we were doing at the Department of Health looking at changes in dementia care and support and achievements over the last 5 years. And one of the interesting things I didn't know, the extent to which the Department of Health and Health Education England and others are putting resources into the training. Now, it's interesting how the number of people in health professions who are now dementia aware and have had specific dementia training has grown very rapidly, much more so than the social care sector. Social care is lagging behind in that respect. The social care workforce and the skilled and expert in that area, there are other challenges in the social care workforce, so I think the challenge is absolutely right. We do have to do that, but the problem is it's often low status, high turnover occupation, and that makes a additional difference.
Great. we've got one last question there from the lady that was by Daniel. If you use the mic and say who you are, that'd be great.
My name is Angela Richards. I'm a student studying clinical neuroscience. I'm also a volunteer at Sussex. I went to a talk about primary care, and it was run by some clinicians, and they were trying to look at people in mental health they couldn't get to, and they put the groups they stood about in 3 different categories. One was those in primary care, those in secondary care, and those in not known about. And I wanted to bear in mind one of the talks I think we've done, I think neurologists, who was saying that there's kind of communities that they don't know about. I wonder how you're actually going to be including them. I mean, I'm a dementia friend. I'm going to become a dementia champion. So I will be able to maybe go to my community, and I'm setting up a group quite soon actually just to do that. But I'm wondering how you are going to get about the not known. You can get to the primary care and the secondary care. And I thought that what that lady said, that epidemiology was really, really important, and we should really take note of that, of what's missing that we don't know about.
No, I think it links to what she was saying earlier about the low rate of, and we're still up to below 50% diagnosis rate for dementia, even though there's been some improvement and can improve it further. So, I mean, hopefully with the epidemiological data sets that we use, they do pick up the full population. Of course, there are some people that still miss, and maybe a little bit missing, but we definitely want to try and do that. And I think as Carol also said, that we know that there are some communities in the UK where the level of access to services, rate of access is lower than it would be in other communities. That may be for all sorts of reasons. We need to understand that. We need to understand what the barriers might be to those access to better quality care. So you're absolutely right. And I think understand that given that more than half of people with dementia in this country are not identified with their dementia or treated, we need to be sort of on our way to it.
So thank you very much everybody for those questions. We've now got tea until 22, so that's probably more than one cup of tea if we're lucky. Think of more questions and make sure you use the notice boards and things outside, and we look forward to seeing people back to the panel session at 3:40. Thank you.